Good afternoon, everyone, and welcome, new friends, old friends, to Mrftt HIV STI Echo. I am Dr. Greg DuBois. Next to me is Dr. David Musa. You can't see it, but he lost the beard, so the beard is gone. And I want to welcome a special welcome to both Conrad Mitchell and Dr. Chris Behrens. And we are privileged that you are giving us the first session of 2022 and our 63rd session overall. So, you know, our little baby is getting long in the tooth. And given everything that's been happening, I don't think we could have had a better first session than to hammer down and figure out, yet again, what's going on with COVID. I remember one of the reasons I decided to stay in HIV medicine was that there's always something new to learn. Right? A couple of every conference, every few months, there's something new and revolutionary and exciting. And COVID-19 is almost like that, but on steroids. Every few weeks, every few days, there's something else that we're figuring out about this virus. Some of it is alarming, but all of it, thankfully, is pointing us in a direction towards ending this pandemic. So the more we learn, the better we do, the more lives we save, the faster we get to the end of the road. And hopefully, similarly, the same sort of way that everything we learned with HIV is feeding into other, not just infectious disease research, just a better understanding of the human body in general. Hopefully, everything we learn from here helps us face the next pandemic with greater alacrity and greater vigor. So that being said, welcome particularly to our friends from Eric Williams, Stacey Thomas and colleagues, and Dr. Behrens. I'll turn the floor over to you. Thanks again.
All right, thank you. Thank you very much, Dr. Boyce. And yeah, it's really a pleasure and honor to be invited back. And I am going to share some information specifically really about the Omicron variant, because honestly, that's what we're all, that's what we're all confronting right now. It is, if it isn't already the dominant strain in Trinidad, it certainly will be in the very near future, given the way we've seen this play out everywhere else in the world. So the usual acknowledgements and credits to our sponsors. I have no relevant financial disclosures. Learning objectives pretty straightforward. Updated knowledge about Omicron. And so just to jump right in, what distinguishes Omicron from prior variants is the really dramatic increase in the number of mutations in the spike protein, which is what the virus uses to basically get into our bodies. It's the spike protein is what binds to the ACE2 receptor on the surface of tissues in the lung and elsewhere. And this extraordinarily high number of mutations seems to give the Omicron variant the ability to better evade the host immune system, as evidenced by greater ability to infect those who've been vaccinated and those who have been previously infected as well. So these are data from South Africa that show that Omicron is clearly better at infecting people who have had prior infection. And when I say better at infecting, I mean it's an individual who has already had COVID can more easily be reinfected with Omicron as compared with the prior variants that have come through. In this specific instance, the South African researchers looked at Delta and Beta. Now, globally, we are seeing Omicron causing a huge spike in cases that far outpaces all prior waves. And this is due to it being far more infectious and to being, as I mentioned, better able to infect those who have been vaccinated and or have had prior illness. And really, we see this everywhere the variant hits. We see this immediate and dramatic near vertical spike in cases. And we've seen this on 4 different continents. And this is why I say wherever this lands, it promptly causes a dramatic spike in new infections. Same story here in the United States. Within a matter of just about 3 weeks, the Omicron variant displaced the Delta and is now by far the most dominant variant. In fact, these data are a little bit dated by now, and it's certainly at least 97% of the circulating variant. Some areas, though, were actually already struggling with a big Delta wave when Omicron hit. So it has really been a double whammy for some regions. In the United States, we have seen a spike in cases that more or less mirrors what has been seen in the rest of the world, not surprising. The number of patients hospitalized has gone up dramatically as well. The number of deaths, not quite so much, and we'll talk more about that. There has been an increase, to be sure, but not at a degree that sort of is pacing with the increase in cases. However, the increase in cases that we're seeing in the United States is, if anything, probably an underestimate, because frankly, it's rather difficult to get tested here in the United States right now. There aren't enough test kits for home use. The testing sites themselves are overwhelmed. And so a lot of people are simply not getting tested, or if they are getting tested, maybe they're using home test kits, and those results are not reported, nor reflected in national statistics. So arguably a more accurate way to assess current level of infections is through these sampling of sewage, of wastewater. And because the overall level of COVID in sewage is a pretty good indication of its level in the community. And here are some data from Boston showing just how high a spike we're seeing there in the state of Massachusetts in terms of levels of the SARS-CoV-2 virus. San Francisco very recently reported some rather shockingly high percentages of patients testing positive. Of those who are having any symptoms of a upper respiratory infection, nearly 50% of those individuals are turning out to be positive for COVID. And what's even more striking, I think, is that there's a lot of testing that is done of people who are completely asymptomatic, and they're getting tested only because, let's say they're traveling, or they've just traveled, they need to go back to work and need a test, or they're doing a procedure at the hospital, therefore need a test. But over 12% of these individuals in San Francisco are testing positive, even though they have no symptoms whatsoever. And so if you sort of extrapolate to the general population in San Francisco, which is, by the way, a city with a very high vaccination rate of about 80%, you find that roughly 1 in 8 individuals who have no symptoms at all are likely to have the Omicron variant. Now, so the epidemiology, the infectivity, the spread of it is obviously very dramatic and sobering news. There is a bit of good news when it comes, however, to reviewing the severity of Omicron infection. Very early on in the outbreak, physicians reporting from the Tishwani District Hospital in the Hoteng province, which is where we think this variant originated, reported that patients who had this illness just didn't seem to be quite as sick as had been expected, and not as sick as patients had been during prior waves with, let's say, the Alpha or Delta variants. And those same hospital officials and researchers have started reporting sort of more complete data from that region of South Africa, again, the Gauteng province. And this is from a preprint. It hasn't yet been peer reviewed, but their initial findings are that when you look at the different variants, the proportions of patients who get Omicron are lower in terms of having to be admitted to the hospital, needing oxygen, having severe disease, or dying, as compared with prior waves that involved variants such as Delta or Beta. So these data suggest it's basically a milder course of infection if you get Omicron as compared to prior variants. And there are, and if you break down the data more in a more granular way, as these researchers reported, those benefits seem to extend across all age groups, and pretty much no matter how you look at the sort of severity of illness. The length of stay in the hospital seems to be significantly less for Omicron as compared with prior variants, as is percent of patients who need oxygen, need to be admitted to the ICU, have severe disease, et cetera. So there's good news in that this variant seems to be just a little bit less virulent as compared to prior variants. Now that was South Africa, and right, it'd be nice to see, well, you know, does it play out in other regions as well? And in fact, we are seeing evidence from other parts of the world that in fact this variant is less virulent. These are data from the United Kingdom, which is shown, just like everywhere else, a dramatic spike in cases with the arrival of Omicron. But the number of patients who are needing ICU care and being on ventilated, while it's going up, it's not really tracking as strongly with the number of cases as one might have expected based on experience with prior variants. So if you sort of look at these data that have emerged from South Africa and from England and try to sort of quantify the virulence of this new variant, from South Africa, they found that the Omicron seemed to be dramatically less virulent as compared to other variants. England, definitely less virulent, but perhaps not quite as much. And we are dealing with the same virus here. I think the difference that we're seeing here could perhaps be attributed to the rate of prior infection in the past, because it's important to remember that we're dealing with a different variant, but we're also dealing with a different time period now, because South Africa had huge waves in the past of Beta and Delta. And even though Omicron can clearly has the potential to infect people who have had prior infection, it's less likely to cause severe disease in people who have had prior infection. So a lot of this sort of apparent loss of virulence of Omicron in South Africa may be due, in fact, to the fact that such a high proportion of the population there had already had COVID, and therefore already had some protection, at least against getting severe disease. Less so in the United Kingdom. A lesser proportion of the population had already been infected. Nevertheless, broadly speaking, seems to be a less virulent strain. We've seen data now emerging. This just came out earlier this week, in a study from a very large health maintenance organization in Southern California that looked at severity of illness of the Omicron variant patients in green as compared with Delta in purple. And no matter how you measure it, symptomatic hospitalization, ICU, ventilation, mortality, Omicron variant associated with a lesser risk of progression to those clinical endpoints. So why is it less severe? Well, I've mentioned the impact that prior COVID, as well as prior vaccination, may be having in terms of protecting individuals from having as severe disease this time around. But there are emerging data that suggests that there is something intrinsic to the virus itself that makes it less virulent. And that specifically is the fact that it appears that this variant is less able to bind to receptors in the lung. And so it's just less sort of pulmonary tropic, you might say. More likely just to remain in the upper airway region where it causes, a bad cold, but at least it's not as likely to get down into lungs and cause severe disease. This is from one of those studies that sort of purports to, show evidence around that. I can't explain exactly what it's showing, but I wanted to include it because it's such a beautiful slide. So no questions about this slide, but enjoy. All right, so what we are seeing in the United States, though, is despite the fact that this seems to be a less virulent strain, nevertheless, the hospitalizations are going up dramatically as well. And in fact, we have exceeded prior records for the number of patients hospitalized with COVID here in the United States. And you might ask, well, how can that be since it's a less severe strain? And the truth is, it's just the sheer volume of new cases. Even if it's a lower per person risk of needing to be hospitalized, you couple that with a huge increase in the number of people infected, and you still end up with a very large spike in hospitalizations. That can be very problematic. Pediatric hospitalizations are similarly have risen dramatically with this, again, far outpacing prior waves. So, the good news is severe morbidity and mortality remains very rare among this pediatric population, but pediatric hospitalizations are also way up. The number of patients in the ICU across the United States is also reaching, and in many states has already exceeded prior records. Again, a less severe strain, less likely per person to result in ICU admission, but it's just the volume of cases that is driving up the need for ICU care. This is what we're seeing here where I work in the University of Washington medicine system. We're at record highs for a number of patients hospitalized with COVID, and a substantial portion of those are in the intensive care unit as well. Some local forecasts for the state where I live, Washington State, suggests that we've got a long way to go as well. We may only be sort of halfway up the slope of this peak. So things could be difficult, to say the least, in the next 4 weeks or so. Same story for ICU beds also. And so these are local data, but I present this because I think it's likely to be relevant for pretty much anywhere the Omicron variant lands. And so I think, in Trinidad, for example, you should be prepared for a possible very large spike, not just in cases, but also in hospitalizations and patients who are severely ill, even though, it's a less virulent form of the virus. The impact on healthcare systems here in the United States is really becoming dire. It's sort of a twofold hit. One is the large number of patients who are now needing care, which again, we're breaking records for that in terms of both hospitalizations and ICU care. But what's really sort of potentially even more problematic is the fact that our healthcare workers themselves are catching this. And while they're not getting, by and large, severely ill, having been vaccinated, nevertheless, any healthcare worker who catches Omicron has to be absent from work for at least 5 to 10 days, if not longer. Our hospitals are already kind of strained by staffing shortages. And so this is the concern moving forward. There are already some hospitals that have had to shift to what's called critical care deficits and crisis care protocols. The kind of sort of care triaging systems that are typically implemented in the setting of a mass disaster where, you know, healthcare facilities are just completely overwhelmed and you have to start triaging patients and really reserving your resources and making some very difficult decisions. So just to summarize what I presented so far, we know that Omicron is far more infectious than Delta variant, up to 3 times more infectious, probably owing to these novel mutations in the spike protein. Wherever Omicron lands, it rapidly displaces Delta, typically within a matter of just a few weeks. The WHO has estimated that half of the population of Europe could soon have COVID if current trends continue. On a per person basis, Omicron appears to be about half as dangerous as measured by hospitalizations as Delta. Again, probably due to this combination of it being less tropic for lung tissue, and this time around, many more of the target population, patients who might be infected with Omicron, have already been vaccinated and or infected. But it should be emphasized, for those who are unvaccinated, this is still a very dangerous virus, especially those with risk factors. And when you put those two together, this is a quote by actually one of my mentors during med school: 50 to 70% milder times 5 to 10 times more cases equals a lot of badness. So very high numbers of patients requiring hospitalization, ICU care here in the United States, reaching or exceeding peaks from prior waves, straining the healthcare system. So what do we do? What are our options here? Well, first and foremost, getting vaccinated if at all possible. The vaccine still affords significant protection. And while the vaccines are not quite as effective against Omicron as they were versus Delta, they still offer the kind of protection that really matters, especially if you can get the full 2-dose series initially, plus a booster. Now, different ways of measuring effectiveness of vaccines. This is looking at just the effectiveness of preventing any kind of infection. So how effective are the vaccines at preventing you from testing positive for Delta versus Omicron? And what this slide is trying to tell, and it's kind of a busy slide, is that the efficacy of our vaccines, whether you look at the AstraZeneca vaccine, the Pfizer, the Moderna vaccine, not as good against Omicron as they were against Delta, and they tend to really sort of wane in effectiveness over time. However, as is shown in sort of the far right, if you can get a booster shot with one of these messenger RNA vaccines, either the Pfizer or the Moderna, that dramatically improves the ability to ward off infection with the Omicron variant. Now, even with the booster, the effect does wane a bit with time, but not dramatically so. And it's definitely worth getting that booster if you can. Now, what about protection against symptomatic disease? And this is arguably a more relevant consideration. So these are data reported from the United Kingdom about their experience to date. In this graph, we're looking specifically at individuals who got 2 doses of the AstraZeneca vaccine as a primary course, and then got a booster with either Pfizer or Moderna. And that is what's recommended for individuals who got the AstraZeneca vaccine as their initial course. And we see a similar pattern as before. less effectiveness, broadly speaking, of our vaccines against Omicron as compared with Delta. And furthermore, the effectiveness sort of tapers off over time after that initial vaccination series, such that the effectiveness in preventing symptomatic disease is really pretty negligible several weeks after completing the AstraZeneca vaccination series. But following a booster shot with either one, the level of protection rises dramatically. Not quite as high as we achieved against Delta, but still really quite significant benefit to getting that booster vaccine. Another study also looking at efficacy against symptomatic disease, this time looking at individuals who got their primary vaccination series with either Pfizer, as a primary vaccine, and then a booster of either Pfizer or Moderna. Pretty much the same story. Not as effective against Omicron as it was against Delta. Efficacy of that primary series really tapers off after several weeks after completion of the 2-dose primary series, but boosting dramatically improves effectiveness. Again, this is against symptomatic disease. They also try to look at people who got the Moderna as a primary course. And they don't have enough data to say what the impact of a booster is for those individuals. But if you get Moderna as your primary series, well, the efficacy against Omicron, unfortunately, sort of drops significantly after several weeks. Again, this is a rationale for getting a booster. And honestly, I suspect it'll end up looking kind of like these data once they accumulate enough experience with that specific combination. And then the last way of really assessing the effectiveness of our vaccines is looking at how well does it protect against hospitalization. And in terms of sort of both individual and public health perspective, you could argue that this is really the most important metric to consider. So less data for that. For the UK investigators, which is why they sort of pooled all the vaccines together in this analysis. But I think the most important column here is perhaps to look at on the right is the vaccine effectiveness against hospitalization. So after a single dose of one of our vaccines, risk of hospitalization cut in half. And this is against Omicron. Shortly after completing a second dose of the series, the vaccination is about 72% effective. Not 100% effective in preventing hospitalization, but a dramatic reduction in risk. However, over time, we see that waning efficacy of the vaccination. And it drops down to only about 50% protection after several weeks after completing the primary course. But if you can get a booster, it spikes, it jumps right back up to 88% protection. And so these vaccines, while they're not quite as potent against Omicron, they really do the job where it's most important, which is preventing severe illness that would require hospitalization. And so I think that this is the message we need to be stressing to pretty much everyone in the community, because they may be hearing that the vaccines aren't effective, you can't get it, you can still get Omicron even if you've been vaccinated. But what really matters is if you get vaccinated, and especially if you can get boosted, you're going to be dramatically protected against needing hospitalization for severe disease. We kind of see this play out epidemiologically in various places. Portugal, for example, 90% of the population there is vaccinated. And like everywhere else, they saw a dramatic rise in cases when Omicron hit. But if you look on the bottom graph of deaths, you see, in that same area, despite the surge in cases, there the mortality just hasn't really budged. And that's because the vaccines are so effective at preventing severe disease. The same, unfortunately, may not be true at all for countries that do not have that high of a vaccination rate. And in fact, as early data, we are starting to see significant spikes in deaths in some of these countries where we have very low vaccination rates. Here in the United States, it's kind of the same pattern. If you look at hospitalizations in New York City, almost entirely people are not vaccinated. Another study from another state here in the United States, almost all the people who are hospitalized in the ICU on ventilators are those who are not vaccinated. And local data from the region where I work, again, if you're not fully vaccinated, you're over twice as likely to test positive. You are 13 times as likely to be hospitalized as compared to those who are vaccinated, and 27 times more likely to die of COVID-related illness. And I just want to include a pitch for vaccinating children. I don't know if that's available yet in Trinidad, but if and when it does become available, definitely worth doing. It's been very rare to see significant side effects from these vaccines, and they're very effective, and especially in the context of the dramatically rising rates of hospitalizations. There have been reports of myocarditis, inflammation of heart muscle, of heart tissue, in children and adolescents who receive the Pfizer vaccine. These have resulted in precisely 0 deaths here in the United States, and the rates are very low. These are rates per million dose administered, by the way. And these rates are actually lower than the rates of myocarditis seen with COVID itself among these age groups. So it is a real side effect, but it's very rare, not fatal, and less likely to occur from the vaccine as opposed to occurring with infection itself. All right, so moving on from vaccines, another thing that's critically important in the age of Omicron is masking, and masking works. These are Washington State projections where I live, modeling estimates by a group at University of Washington that estimate how is this Omicron variant going to play out epidemiologically. And they adjust their models based on certain scenarios. And one of the things they do is they model what will happen with the epidemic moving forward if, say, we could persuade 80% of the population to consistently wear masks when they're in, say, indoor congregate settings. It would have a dramatic effect on the number of cases here in Washington State and elsewhere, frankly. And it's because masking works. Now, not all masks are equal. And I think we perhaps haven't done enough messaging to the general population about the difference in quality between different masks. And I think it's important that perhaps we revisit that given just how contagious Omicron is. Because cloth masks, to be honest, aren't nearly as effective as these surgical procedure masks, or for that matter, masks that are rated as N95 masks. And so this kind of helps to chart out risk of contracting COVID according to what mask a patient who has COVID is wearing, and what mask a person who does not have COVID but it is being exposed to that person is wearing. And so, of course, you get the highest benefit from what are called N95 masks. These are some more detailed studies that just to, not that it's worth remembering all these details, but I guess I want to point out that there have been some very high quality detailed studies evaluating the effectiveness of different kinds of masks in terms of reducing the risk of aerosol penetration. With N95 respirators, of course, being the best, especially if they've been fit tested, et cetera. But you know what? These surgical masks with ties, they actually do really well also. Looking at that graph B, the procedure masks probably, not as effective, but definitely have some impact. And again, better than cloth masks. I think some of the best ones out there that you might be able to get commercially are what are called KN95 masks or KF94. For a KN95 masks, the K refers to simply testing according to the sort of standards used in China, which for all intents and purposes are roughly equivalent to the ones used in the United States. And so KN95 masks, they're not necessarily fit tested, et cetera, but they do tend to be, reasonably comfortable to wear. And the materials in them are layered in such a way that they are actually very effective at absorbing and preventing these aerosols from getting through. You might also see what are called KF94 masks. The KF in that situation stands for Korean filter. They're made in Korea. They block 94% of particles, 3 microns in diameter or larger. So, the difference, I think, is trivial. And then I wanted to just sort of briefly mention this study because it provides further evidence about the efficacy of masking. It provides evidence about the how effective certain air filters can be used if they're HEPA air cleaners that we now know, fortunately, are effective at filtering out the aerosols that contain the SARS-CoV-2 virus. And frankly, I think, this is more relevant here in the United States in colder climates where we cannot do natural ventilation. But we know from other scenarios and other studies that natural ventilation is tremendously effective at reducing the risk of transmission of infections that are borne by aerosols. So what this study showed, without going too much into the details, I think the first thing worth noting is just what an impact masking had, regardless of the sort of filtration system used in a given indoor area. Masking dramatically reduced the impact, the risk of spreading. And then using these air filters also helped quite a bit. And so we've always sort of hoped that air filters would work where we cannot use natural ventilation. And I think this study really lends support to that. Didn't make that much of a difference where exactly the filters were placed, but as long as they were HEPA filters, they had a very real impact. So moving forward, just sort of in broad strokes, I think we need to continue to rely on the sort of combination prevention approach that we've been promoting all along. We have multiple interventions available that can reduce the spread of COVID. And these are continuing, these will remain effective against Omicron. But no single one of these interventions is 100% effective, which is why we need to pursue multiple interventions at once. And if you layer enough of them sort of on top of one another, by this metaphor, you are hopefully able to plug the holes enough to prevent infection. So just the key points I'm trying to convey here. As I mentioned, this is a far more infectious variant, half as dangerous per person, but still very dangerous for the unvaccinated. And the problem is the sheer volume of new cases is threatening to sort of overwhelm our healthcare systems, and it's going to result in a lot more morbidity and mortality, despite the fact that the individual per person risk may be less with this variant. Levels of immunity and protection against this virus are best achieved by having an original vaccination series using one of the mRNA vaccines plus a booster. We found that individuals who have received those and have had COVID seem to have really strong immune systems, but that is not a recommendation to consider getting yourself infected. After that, if you have one or two messenger RNA vaccines, or the Johnson & Johnson, for example, or just infection alone, more modest protection, whereas those who have had no vaccines and no infection remain completely vulnerable to this. And again, we're going to need ongoing combination prevention, especially in the next 2 months, which is when I think we're going to see the biggest dramatic spike in cases. The modeling suggests we're perhaps only at the start of it. So I'm going to stop there and open it up to questions and discussions, because I'm sure there are other questions that people may have, and I want to really address what people have questions about.
Okay, Dr. Behrens, thank you again for, as usual, a wonderful, very informative and a really engaging presentation. So if anyone wants to ask a question, you can either raise your hand, unmute, and ask a question, or type in the chat box. Because I'm sure there's a lot of things in clarification on even with this new variant and what's coming up down the pipeline. So I'll open the floor to anyone who wants to ask a question. Right. So while everyone's sort of getting themselves organized, let me ask you first, because this is one of the issues as healthcare workers we have been dealing with from the beginning, with the whole blowback about the vaccines that they're not effective, and you're going to have to get so many more as time goes on, and there are memes about this thing. But separate and apart from the sort of anti-vaxxer aspect of it, the real issue of sort of vaccine fatigue. Persons who have done the right thing, go and get themselves vaccinated, and they're hearing, like in Israel, that they're talking about giving their citizens a 4th dose now. And there is, I think, some documentation suggesting that in terms of the numbers of persons turning up for their booster shot, it seems to be less so than the primary series. How do we wrap our heads around that as healthcare workers? And has there been, is it that the messaging was wrong to begin with? Because I think there was always this suggestion that, given what you know about the biology of coronavirus, is that the vaccine response is always going to wane and there would be need for a booster shot. Should that have been communicated earlier on so that people know what's coming, as opposed to it seems like we're sort of caught their pants down and now starting to catch up with booster shots and this sort of thing?
Well, early on, we just really had no way of knowing how well the vaccines were going to work, how long they would work. These were totally unknown questions. So, I think all the public health experts, acknowledge that. I think then when we had these vaccines that were far more effective than our wildest hopes and dreams, obviously we were thrilled, and we should still be thrilled, because without these vaccines, this would just be, it's already a pretty bad virus, pandemic, et cetera. But imagine just how much worse this would be if we didn't have the vaccines at all. In retrospect, sure, it would have been nice to know up front how this would play out, that we'd be needing boosters, et cetera. But, that's obviously not possible. Moving forward, I think what we need to do is keep emphasizing just how amazingly effective these vaccines are at preventing serious illness and death. And unfortunately, that message is getting lost, I think, due to all the news about how, let's say, the Omicron is so good at evading our vaccines. I mean, that's only true to a point. It's you can still get infected with it, but you're not going to get seriously ill. Extremely unlikely to be get seriously ill if you've been vaccinated. So so breaking through all the fog and noise of misleading, if not outright misinformation, is just the ongoing challenge here. I just think we need very simple and public health statements that say the vaccines will keep you out of the hospital or keep you from dying. And that just needs to be, stressed over and over and over again.
As Dr. Boyce has alluded, the government of Trinidad and Tobago, through the Ministry of Health, has been encouraging the population almost on a daily basis that vaccinate. It prevents you from getting severe COVID symptoms and avoiding ICU requirements. But there are these really, really determined anti-vaxxers who would come up and say that is not true, you don't need the vaccine. Is there any way this message should be put to the population? Number two is that those who get 3 doses of messenger RNA vaccines are super immune, plus infection, are super immune. Now, does it matter whether the infection occurs before vaccination or after? And any idea how long this super immunity lasts?
Okay, so so to address the first point, it sounds like the messaging has been appropriate, but you've got a population of vocal and vigorous anti-vaxxers. I hope that wasn't some sort of contagious anti-vaxxer contingent that we brought from the United States, because we certainly have our fair share of that as well. I don't think anybody has a clear answer to, the anti-vaxxers. It's other than continuing to try and present the truth and to discredit the misinformation coming from the anti-vaxxers. In terms of concrete steps, here in the state where I live, health professionals who peddle misinformation about COVID can lose their license. Disciplinary action is taken against healthcare professionals who, just disseminate misinformation. And I think that's appropriate, right? I think our first responsibility is do no harm, and of course, spreading misinformation is very harmful. So that's the right messaging. I don't have, I don't think anybody has a magic bullet, so to speak, against defeating the misinformation from anti-vaxxers, other than continuing to stress the truth, the reality, and hope that it sticks for enough people. If you can get celebrities, highly public figures, that often does the trick. We certainly saw here in the United States with HIV, we really, in the early days, we really didn't turn the corner on stigma and discrimination, on many fronts, at least, until we had certain celebrities, getting involved and going public and making statements in that regard. So I don't know what the local climate is like in that front, but if there are popular musicians, steel band performers, that sort of thing, if they could come out and do public service ads in favor of vaccinations, that could go a long way. So just some ideas. In terms of the second question about this, so-called super immunity, I don't think it was at all teased out when that infection occurred, whether it was before or after or in the middle of the vaccination series. Furthermore, it might be a bit different from Omicron. The super immunity that's more really based on levels of neutralizing antibodies, so to speak, these sort of surrogate markers for immunity. And I mean, it's out there, but it really shouldn't influence our behaviors at all. You certainly don't want to go out and get yourself infected. And how long it lasts, also totally unknown. But it is kind of an interesting finding that supports the general principle that if your system is challenged to respond to this, either by vaccination or by natural infection, typically you're going to get some protection from each step in that process.
Dr. Behrens, we have a question in the chat box, and then we have Alana has a hand up for a question. In the chat box, it says, you spoke of gauging the spread of the virus by way of testing sewage water. What is the probability of persons contracting the virus from using toilets used by persons who are COVID positive but asymptomatic, or those confirmed as COVID positive?
Right, good question. So again, we're testing sewage water just as a way of trying to sort of track on a broad epidemiological basis what's the level of of the virus in a particular community. It doesn't seem to be very efficiently transmitted at all via, say, fecal oral transmission. I remember seeing like a case report that of possible spread in that manner, but I don't think it's panned out as a meaningful means of transmission at all, because I've heard nothing further about that since seeing that sort of possible case report.
Alana, you want to go ahead?
Yeah, sure. Actually, my hand had gone up when Chris made the comment that it would be good to use local celebrities if we could to spread the message. And I was thinking about vaccine hesitancy and how there's a certain point after which there's this saturation where people who are against taking the vaccine, it doesn't seem to matter what information is presented to them or what examples are given. Case in point, very recently, we did have a lot of our soca artists have come out and talked about being vaccinated and encouraging the population. We recently had a death of one of these soca artists, and you would think that one out of, because no one ever said that if you got vaccinated, there wasn't, that would never occur. It just means we've been showing the statistics that show deaths among vaccinated versus unvaccinated, and yet the messages that we kept seeing, or at least I kept seeing, and the people in my groups kept seeing, as like circulating the video of this soca artist saying, you see, he was vaccinated and he died, and they're completely ignoring, the fact that that's such a minute percentage. Or so I think I've come to the conclusion that there's some people who are really very dead set, and maybe I don't know what percentage of people how their minds are actually going to change at all, because nothing seems to be working.
Yeah, I agree. There's a certain percent of the population you're never going to be able to reach and persuade. So I think we have to resign ourselves to the fact that fact. But that doesn't mean you don't keep trying, because it's hard to know who those people are, and it's hard to know if maybe eventually something will change in their thinking.
We have a subset of population that they don't want to be vaccinated because they are waiting. When you ask them what they're waiting for, the answer is that they are waiting. Do you have such population in the US?
Yes, I have heard that, and I've had individual patients that I see who have said that, and my approach is to say, no, you cannot wait. You have to do this now, and I just I'm very frank to the point of confrontational in stating just how severe the current outbreak is, and how they just, it's too late. You cannot wait any further, And I've actually had some success with that approach of just, I don't know, being a little bit more, I guess, almost borderline confrontational with them about the importance of getting this done. I mean, I cite the evidence, et cetera. I ask what their questions are, what their reservations are, et cetera. But in the end, I say, you can't wait any longer.
We take the final question from Dr. Seabrook.
Dr. Behrens, thanks again for such a really great presentation. My question is, in terms of managing the conversation of risk reduction for people who have weaker immune systems, where some patients, even though they do get vaccinated, they do present, and knowing that we will, as more people get vaccinated, the people who we might see, we will see evidence of people who might be vaccinated who may have had some challenges. So how is that conversation being managed? Perhaps where you work, I'm assuming it's more so a one-on-one, because the global message is on vaccination, and I know we've not been doing some of the follow-ups at an individual level, but how is that conversation being managed? And I hope I'm getting my words out right. And how would you recommend in terms of how we approach that risk reduction conversation with some of the clients that may have lower CD4 counts?
Sure. So individuals who perhaps are not responding as well to the vaccines, are less likely to, really they need to double down on isolation and avoiding contact with others in the community. They need to make sure that their family members are vaccinated. And this actually reminds me of an approach to the vaccine hesitant that I think is worth talking more about, and I forgot to mention earlier, which is that there are a lot of people in our community that for whom the vaccines are less likely to work, those with severely depleted immune systems. Those people really depend on the rest of us to be vaccinated in order to reduce their risk, right? So, for all of us, I think we need to get vaccinated, not just to protect ourselves, but also in order to protect the most vulnerable in our community. Those people depend on us to get vaccinated. And it really resonates with the sort of messaging in Christianity and virtually all other religions that it's incumbent on us, it's our duty to protect those in our community who are most vulnerable. And so if you're serious about that, that duty, then vaccination is something that really you're sort of obligated to do. I actually, and I'm glad you brought this up, because I'd forgotten that I have used that kind of counseling with some success as well, among patients of mine who, are religious, have faith that guides their personal decisions. So I don't know if that answers your questions, but I think that kind of messaging, especially from faith leaders, within their congregations, during services, public broadcasting, I think that perhaps could go a long way for persuading the vaccine hesitant that it's not just about you, it's about protecting the most vulnerable. And this is, the message of Christ, as it were.
All right. Thank you very much again, Dr. Behrens, for the session. Thank you for all our participants for what was a really interactive session. And I think it's about that time now, so we'll wrap up today's session. And again, I want to welcome all the persons who joined us for the first time in 2022. We welcome you to our learning family here at HIV STI ECHO. And we want to just advise you that the next session is going to be back on a regular day, which is on Thursday at 2 p.m. local time. And it will be a HIV session just to bring out some of the new members up to date. We rotate HIV sessions, STI sessions, psychosocial sessions, and Dr. Behrens' special invited session on a sort of rotating 4-week cycle. The next session will be an HIV session, and hopefully there will be a case discussion as well, which is how our ECHO's session is formatted. We want to get your ideas, your participation. What would you like us to present? If you can get in contact with us either through the WhatsApp group or through the email chain, and just let us know if there's any topic in particular, whether it's HIV or STI or psychosocial session related to HIV and HIV management that really piques your interest. So again, thanks to all of you. Thanks to Dr. Behrens. Stay safe, stay well. We shall see you in 2 weeks' time. And that's it for us. Welcome, Linda. Take care, everyone. We're off. Bye-bye.
Bye now.